first thing to do is to be sure you've got an accurate diagnosis of Asherman syndrome. This can be done by ultrasound scan, so you can see whether the endometrium is thin, and sometimes you can actually see adhesions or loss of endometrium present in the uterus. And then the treatment is surgical. We then do a hysteroscopy, which is where a small telescope is introduced through the cervix or the neck of the womb into the cavity of the womb. What's really important is that we're absolutely certain that that hysteroscope is in the true cavity of the uterus. When the cavity is obliterated, it's very easy for the scope to slide either behind or in front of the uterus, and when that happens, we can cause more damage than we do good and create a false passage or try to develop a false cavity in front of where the endometrium really ought to be. For this reason, I tend to do hysteroscopic procedures under ultrasound and X-ray control so that we can be completely certain that we know where the hysteroscope is and accurately locate what's left of the endometrium to try to effect as good a repair as possible. Once the surgery is completed, we then need to use either a stent or an intrauterine contraceptive device to hold the wall of the uterus apart so that the adhesions won't reform. And the other very important aspect of treatment of Asherman syndrome is to ensure that we give high-dose estrogen treatment immediately after surgery to make the endometrium grow as thick as possible, as quickly as possible, so that new adhesions won't form at the site at which we divided the old ones.